feeling, it's a reality. This is data from a large German cancer registry covering more than 30 million citizens in Germany, and you can appreciate that actually myeloma is really the champion in terms of survival improvement. And these good news are related to the introduction of all of these novel agents. Nevertheless, I think despite our enthusiasm and excitement about all what has been presented today from these different phase 3 trials, which led to the approval of second-generation proteasome inhibitors, we should bear in mind that the outcome when you go to a late myeloma stage is going to be really very dismal. And this is still an unmet need, and we need to be really transparent on this with our patient. And this is the reason why there is still room for improvement, and there is still room for all the different families of drugs. And I'm sure everybody's familiar with this wonderful slide from Enrique Ocio from Spain, which nicely summarized the different available options. And when you look carefully in more details, you can appreciate actually that the HDAC inhibitors are really players on this scene. And there was 5 years ago, I would say, a lot of enthusiasm and excitement about HDAC inhibitors. Unfortunately, there was excitement until we had the results of Vorinostat. Nevertheless, I think when we speak about HDAC inhibitors, we are actually speaking about a more global process, which is epigenetic modulation. And why do we need epigenetic modulation? Actually, I'm sure many people in the room beside myeloma treat other hematologic malignancies. And actually, epigenetic modulation, whether HDAC inhibition, hypomethylation, or other processes, are actually now very popular in the field of hematology. This is data, for example, in AML, showing already that epigenetic modulation in AML, in older AML, can lead roughly to similar results like to intensive chemotherapy. The problem we have faced is that we were a lot disappointed after the release of this so-called VANTAGE trial in myeloma, which tested the combination of bortezomib and Vorinostat. So this trial met its primary endpoint, of course. This is a famous p-value. Nevertheless, the difference in terms of PFS was not thought to be clinically meaningful. And this is why I would say the excitement dropped down progressively, and people moved a little bit from these families. However, I think we need to bear in mind that although everybody's claiming myeloma is a chronic disease, there is room to cure a certain number of patients, or at least to have long-term remissions. And if you want to achieve long-term remissions, obviously the novel agents already described, the value of MRD, the maintenance described by pharmacologic agent is definitely great. But if we want to push it forward, this is going to be definitely the era of immune therapy. And the era of immune therapy to further deepen the response, but also maintain this response. And this is probably the most powerful anti-tumor mechanism of action. So immunotherapy can be active, like what we heard from Dr. Rodriguez. It can be adoptive immunotherapy, but you can also modulate tumor antigen expression. You can also play on the epigenetic processes. And I will not spend a lot of time because a lot has been said today about the different changes we have in the host environment, whether when it comes to changes in the different regulatory T cells, the involvement of inflammatory cytokines, or all the other immune defects which were already nicely described. Nevertheless, in this process, we should bear in mind, this is a paper published in Cell 6 months ago about the inhibition of DNA methylation, which is a major epigenetic process. So when you use DNA methyltransferase inhibitors in this very strong data, it was clearly shown that the use of DNMT inhibition can induce an interferon-like response in cancer cells by activating double-stranded RNA sensors. So definitely, in another word, you can stimulate and induce an immune response, and in this paper, they have used a melanoma model. So it's a proof of concept on how epigenetic modulation can induce or can serve as a way to push immunotherapy further. When you look to neoantigens expression in cancer immunotherapy, because of course you need a target, if you look to the wide spectrum of diseases, obviously melanoma is a great champion in terms of neoantigen. This is a paper published earlier this month in Science. Acute leukemia is here. Myeloma is slightly in the middle. So it's in between. So you would say, well, it's like, not black and white, it's gray. Nevertheless, that's not the final conclusion, because one may question if myeloma is here, but maybe it can move differently depending on epigenetic modulation of the different mutations and so on. So, having said this, where do we stand in the clinical setting? Actually, this will be described extensively tomorrow by Paul Richardson. So, this has been published, seminal work from Jesus San Miguel group, and this phase 3 trial established the proof of concept that combining panobinostat plus bortezomib and dexamethasone, you can likely overcome the bad prognosis of bortezomib, for example, refractory patient. And then, of course, the question is, what is the mechanism of action? How does it work? And it is likely, in my opinion, working with some epigenetic modulation. And actually, last week, you may have seen this paper, very strong research paper, published in JCI. JCI is open access, so you can go immediately and look at this paper, which described a very potent mechanism of action of panobinostat, which can induce calcineurin degradation in multiple myeloma. So it's a quite complex model, but to make a long story short, this is the involvement of this molecule, PPP3CA, which is a catalytic subunit of the calcineurin, and this is highly expressed in advanced myeloma. And what they were able to show in this work, that actually panobinostat can degrade this molecule, and the co-treatment between HDAC inhibitor, panobinostat, and FK506 can enhance the anti-myeloma effect. And actually, this combination not only killed the plasma cells, but also blocked osteoclast formation, which we know we need to do in multiple myeloma. And some other aspects of this research work showed very clearly that actually the poor response and the short progression-free survival duration in those bortezomib-containing therapy, because we all know that even when we give the same regimen to all patients, some of them are really great responders, and when you look, they have the same characteristic, but suddenly a few of them do not respond very well, and we really don't understand why it's the case. Well, here you have some approach to explain these issues where, for example, the patient with a high expression of the PPP3CA, probably these patients may develop bortezomib resistance, and this is why it is really important while we are developing all of these, for example, novel proteasome inhibitors, we keep on developing the HDAC inhibitors in this setting because there is a close link with all of this. So in conclusion, I hope that I have convinced you that there is still room for these HDAC inhibitors. Obviously, the current innovations are derived from proteasome inhibitors and IMiDs, and we owe them all the improvement we have observed. However, and we heard a lot from Bart and from other people today, the next wave of therapies will be mutation-driven, but also derived from better understanding of plasma cell biology. And the molecule, the PPP3CA molecule example, is a very strong example. Of course, the immune functions that were very nicely analyzed. If you want to restore these immune functions, it's going to be a hard task because it's not only one dysfunction there, but these small molecules, inhibitors, such as the HDAC inhibitors and panibonostat, but also other next-generation HDAC inhibitors, will be very useful tools towards optimizing and refining the use of these different backbone molecules. And with this, I do thank you for your attention, and I'm happy to take your questions.